Dear colleagues, thank you for the opportunity to present some data on the integration of imaging with histology, proteomics and genomics, the urology perspective at this 7th AdmitTech Summit. My talk is about a transformation in identification and treatment of lethal or metastatic clones of prostate cancer from the treatment with first cut, then see, towards first see and precisely diagnose and then cut. So the program is about modern imaging and diagnostic modalities that can aid and individualize active surveillance. MRI and radiomics predict aggressiveness of cancer, patient-tailored treatment of localized prostate cancer using MRI, detecting local recurrent disease using PSMA PET, and using imaging and radiomics to predict biochemical recurrence. When we use MRI prior to active surveillance inclusion, here are data from low-risk prostate cancer patients. Disqualification rates within a 4-year follow-up can be reduced significantly, as you can see, from a disqualification rate about 20% in men who were correctly diagnosed using MRI and transfusion biopsy, towards up to 60% when initial 12-core trust biopsy was applied and patients were included in active surveillance. So this is a pro for an accurate diagnostic prior to active surveillance. So the next question is whether we can prognose active surveillance discontinuation using the first MRI prior to active surveillance inclusion. So you can see here data from the GAP3 consortium. Over 1,000 patients with grade 1 and 2 cancers were included, and MRI was called suspicious when a pirate score of 3 or above occurred. And as you can see here, active treatment and active surveillance discontinuation were both higher in those groups of men who had a positive MRI prior to inclusion. However, this was not transformable into biopsy or histopathological upgrading, as you can see on the right side. In addition, a matter of combining these data from MRI, from the first MRI prior to active surveillance inclusion, and clinical data, as you can see here in a study from the ERSPC colleagues from Rotterdam, over 1,100 patients were included in over 1,400 MRI scans, and the disqualification rate was up to 50% in a time span of 7 years. However, what you can see on the right side is that you can enhance your predictive possibility of the PIRATES scoring when you add PSA density based on the volume on the MRI. When we talk about accuracy of MRI and of serial MRI scans in active surveillance, we have to talk about a precise scoring. It's not only about the PIRATES scoring from the first MRI prior to inclusion, it's also about the serial MRI scans. And here a 5-point Likert scale can be used. It's nearly the same like we have in PIRATES with a precise score of 3, meaning that serial MRI is stable up to 4 with a significant increase in size of the lesion, and 5 is a definitive radiological upstaging or stage progression. Does this work? Yes, it does. 8-year follow-up from the precise data over 600 patients from the University College of London. And as you can see here, progress or not using precise scoring. In case of progression, there is an upgrading in over 50% of patients. And in case of a stable MRI, the chance to omit early biopsy is valid in approximately 25% of patients. Information led us to a study that we perform at the University Hospital of Düsseldorf, the PROMAS study. PROMAS study is a study including men with low and favorable intermediate risk prostate cancer, and stratify them and stratify follow-up biopsies by MRI, meaning that if an MRI and a follow-up is stable, the patient forego follow-up biopsy up to 2 years. So after 1 year on active surveillance based on MRI and transfusion biopsy, the patient underwent MRI, and only in case of an MRI progression, another MRI transfusion biopsy is applied. Otherwise, the patient will get another MRI scan after 2 years, and after 2 years, all patients underwent MRI transfusion biopsy to end the study. 101 patients were included, and we performed an interim analysis. However, what you can see here are that approximately 1/3 of patients were disqualified in both subgroups. These are the results in terms of MRI outcome. And as you can see here on the left side, for the ISOP1 grade group, the sensitivity was pretty high with 94%, as well as the negative predictive value with 88%. On the right side, you can see the ISOP grade group 2 subgroup with a sensitivity of 91% and a negative predictive value that is only about 50%. However, there are only 2 patients who were stable on the MRI. So to conclude, this disqualification occurred in both subgroups in 28 to 30% of patients, omitting 88% of follow-up biopsy ISOP grade group 1 cancers because of stable MR scans. And in case of MRI progression, the termination of active surveillance in over 80% could be valid with ISOP grade group 1. And there is the chance to reduce follow-up biopsies. Some other data from our group, multicentric analysis from Cambridge, Dresden, Essen and Düsseldorf. 369 patients were included with ISOP grade group 1 cancer, and the question was, does precise scoring work? Yes, it does. As you can see on the left side, this is the progression rate. Precise score of 1 or 2 occurs. It's only about 5%. So when disqualification is defined by precise scoring 3 or higher, as you can see here, the negative predictive value to rule out is over 90%, and the sensitivity is 74%. So very good data that emphasize that precise scoring is the right tool. Detective Consensus Conference also stated, even in 2019, that inclusion in active surveillance is only valid after MRI and MRI transfusion biopsy. ISOP grade group 2 does not automatically mean dropout, and with favorable parameters, we can also apply active surveillance to ISOP grade group 2 cancers. ISOP grade group 3 is a disqualification, and it's a matter of question if BRCA2 positivity is an automatically disqualification. These led us and led colleagues from University of Cambridge towards using some prognostic factors here, the Cambridge prognostic groups and radiomics, to individualize active surveillance. And they proposed the StratCans group, as you can see on the right side, and depending on the Cambridge prognostic group, you can forgo follow-up biopsies, and you can personalize MRI follow-up scans, as you can see here, not in all cases after 12 months, but sometimes by a follow-up MRI 18 months or 3 years. Does genetic parameters work in active surveillance? Yes, they do. Commercially available are, an example, the Decipher 22 gene scoring. And this predicts significantly active surveillance disqualification, as you can see on the right side, and rules out clinical parameters alone. MRI is a pretty good tool in diagnosing prostate cancer. This is the case because it pretty much shows very nicely the anatomy of the prostate, as you can see here. On the other hand, using DWI and DCE, and it demonstrates neovascularization cell density. As you can see here, putting these 3 sequences together, you have some tumor-specific patterns that they can use. The next step would be integration of radiomics, so radiomic parameters and texture analysis with over 1,000 parameters per patient, and self-learning networks and artificial intelligence, as you can see here in an example on this side. So does it work? Yes, it does. Here, predictive performance of neuronal networks in 2023, detection of significant prostate cancer defined as ISOP grade group 2 on data from the German Cancer Research Center. As you can see here on this side, refined data that outperform pirate scoring on the right side, as you can see here, also a group from the German Cancer Research Center. So what can we do in 2023? Automatic segmentation, machine learning algorithms, feature selection, significant lesion detection, and outperforming of pirate scoring. There is at least a standardized evaluation of extracapsular extension using MRI, and the combination of MRI and clinical parameters can lead to a very good prediction of extracapsular extension or site-specific extracapsular extension that can aid a personalized radical prostatectomy. If you do not believe in MRI alone, that doesn't matter at all. You can use intraoperative frozen sections guided by MRI. Here are data from Giuseppe Petraglia from Milan, published nearly 8 years ago, that can sufficiently guide your intraoperative frozen section towards the MRI lesion. The last step is local recurrence after radical prostatectomy or radiotherapy. Here, EU guidelines pretty clear what to do in PSA recurrence. At least perform a PSMA PET scan if available. And why is this the case? Because a pretty high specificity, here data from 2015 and 2016 in a meta-analysis of 15 studies, pretty high pooled specificity for PSMA PET CT scan with 97%. However, the sensitivity is better than Q-line with over 60%. However, there is some space for improvement. Why is this sensitivity depending? It depends on lymph nodes, on tumor diameter and PSA level. Per se, a lesion detection has a sensitivity of 77%. However, it is lower in PSA levels below 0.2, but the detection rate is pretty high in PSA levels over 1. So it depends on tumor, so it correlates with PSA level and PET avidity. And it also correlates with tumor diameter over 4 millimeters and lymph node diameter over 8 millimeters. Do we have additional value of this extracapsular extension defined on MRI? And the answer is yes. Here are data from Andreas Wittmer of Memorial Sloan Kettering Cancer Center, published last year in Radiology. They could show that an extracapsular extension or T3 state or disease derived from MRI adds significantly towards biochemical recurrence prediction, metastatic disease prediction on multivariable outcome analysis. And when you see the hazard ratios over here, the hazard ratio is a little bit higher than the pathology state. There is some additional value of the MRI T3 disease definition. Do we have additional value of radiomics here in this context? And yes, here are some data published last year. And so what did the colleagues do? The colleagues derived some radiomic textures from the PET scan, so avidity, and from the ADC images of MRI. And as you can see here, this aids prediction of Gleason grade grouping with a pretty high sensitivity and good specificity for stratifying ISO grade group 4 and 5 against 1 to 3. Do we have some value of genomics to predict distant metastasis in a 10-year follow-up after radical prostatectomy? Here, data from the Decipher used, and as you can see here, you have a 10% increase Decipher score, and this translates into an odd ratio of 1.5, which was statistically significant towards prediction of biochemical recurrence. So to conclude, modern imaging with MRI can aid decision for or against active surveillance in men with low and intermediate risk prostate cancer. Serial MRI scans and genomics can guide and reduce follow-up biopsies on active surveillance. In localized prostate cancer, standardized MRI and clinical parameters can help to patient-tailor radical prostatectomy by accurately predict site-specific extracapsular extension and maybe guide intraoperative frozen sections. Radiomics are able to predict significant disease, and in particular molecular imaging with PSMA PET can detect and localize biochemical recurrence, and they can predict biochemical recurrence on long-term follow-up. So I would like to thank you for your attention and thank our groups from Düsseldorf and Heidelberg for the continuous help and the great opportunity to work in this context.